We'd like to
Yes,
virtually. Yes.
How are you?
Huge.
Good evening and welcome to this meeting of the Cloud Social Crime Health. Tonight, I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. This event will be recorded and will be available for members of the public and media to watch following the meeting. Now, I'd like to welcome you all to the council to this committee room at Kensington Town Hall. Before we proceed with the meeting, I would ask members of the committee to make sure their mobile phones are switched off or on silent. And I think it would be appropriate for us to start with 72 seconds silent to remember those who lost their lives in a Grenfell tragedy. And we will start with apologies for absence. Apologies for absence being received from Cleo Chalk, and I think Roberto is en route, and I think Portia is coming too, so I'm not going to note any absences there. Does any member have any interest to declare on these cases? And then the minutes of the meeting held on the 10th of July 2024. The minutes of the previous meeting have been circulated. Does the committee agree to sign the minutes as a correct record? Yes.
No one was there.
Thank you. And then we will move on to agenda item 4, sexual health services. This report set out a range of sexual health services commissioned by the council, the gaps in the service provision, ways of working with and engaging with residents and communities, and recommendations for future service provision. Thank you all very much for this report. And I was going to say to start, Josh Anringer, do you want to start by presenting it? And then Janet, Nicola, and Dominic, who we have here from the gun services team at the John Hunter Clinic. I was going to bring you in afterwards to talk about your work on the front line and any challenges we face.
Great, thank you, Chair. Yes, I'm happy to introduce the report to the committee. As you see from the report, RBKC, along with many other councils, commissions a range of services to help our residents and our wider community. This one today is obviously our sexual health services that are provided right throughout London, but specifically in Kensington Chelsea at the John Hunter Clinic, which is on Fulham Road. Some of you may have been there before, which is basically next to the Chelsea and Westminster Hospital. And the John Hunter Clinic provide a range of services for anyone who perhaps wishes to use their services. I personally have myself, Chair, been a few times. I sought advice. I've got my HPV vaccination there, my monkeypox vaccination there, and other things as well. That personally, from a completely personal point of view, offer an amazing service. And the report lays out what John Hunter can do, how the council will help with that, but also kind of what the suggestions are of the John Hunter Clinic as well. I met with Nicola probably 2 or 3 weeks ago to discuss what the council can do to support some of the asks they may have, if they wish to raise and kind of the service provided. So the clinic obviously serves all for fuel, RBKC. I think one of the challenges which the John Hunter Clinic will recognise is that it's in the south of the borough, so it's somewhat perhaps a bit challenging for people in the north, especially people, as we know, transport connections aren't very good north to south to use the facilities. we're exploring ways perhaps how we can improve that going forward as well. So, but as I said, the main detail is in the paper. It's got a pretty good percentage of people who go to the service for preventive measures or indeed measures to get treatment if they need to as well. But we're happy to take questions on the council's position on that, or I'll leave it to John and to colleagues as the experts to fill in more detail.
Great.
Lead off.
Yeah, sure. So I'm Gurvit, Everything Consultant at HIV Sexual Health and Clinical Lead for the John Hunter Clinic for Sexual Health, as well as COBLA HIV Services at the Chelsea Westminster Hospital and Fulham Road. Thank you very much, Chair, for inviting me to the Select Committee meeting. And thank you, Councillor Randall, for a very positive review. So it's really nice to hear this. So we were really proud of myself to work in a very globally recognized sexual health service provider. We're one of the largest providers of genital urinary medicine care, sexual reproductive health care, as well as HIV care in the UK. We are a free open access service. GUM, so genital urinary medical clinics, are often felt to be just STI testing services, and this is really not the case. We have seen year on year greater complexity in the patients that are coming to us, and that's why we've rapidly adapted really ourselves to meet the evolving sexual health landscape. So we offer psychosexual medical services, urology, dermatology, vaccination and contraceptive clinics, as well as in-house scanning to meet these service user needs. And also within teams with especially sexual health advisors who support individuals with enhanced needs, help them through education to prevent onward transmission, maybe drugs and alcohol issues that come along in a lot of cases, and also to manage safeguarding referrals, which we see a lot of. As partners, we've also worked with the City of London to develop the online testing platform to Sexual Health London, and I think I work along with the lead consultant who deals with this in John Hunter Clinic itself. We've done exceptionally well through the course of the pandemic. I think being a massive access point for online contraception, and 3 years on, 60% of the ladies who come in to the clinic have accessed the service by booking online. Mm-hmm. So it's really great to see this. This is really good to have engaged patients who may not have engaged the clinic previously. Women's health needs have also exploded in this time. Very likely due to being very little LARC. LARC is really standing for long-acting reversible contraceptives. Very little capacity within primary care. And gynecological services as well are quite limited in their criteria to see patients. They're not open access. And then so we're starting to take over the service provision, both simple and complex, long-acting reversible methods. So this is implants, intrauterine devices for women, through upskilling our workforce, having increased number of training clinics throughout the week. And this is aimed not only at internal staff, GPs, and even there's been a lot of international interest for patient colleagues who work in sexual reproductive health within their own clinics. So we've had colleagues from Malta, Ireland, for example. The problem is this is in the absence of any recognised funding pathways. A lot of it is good with colleagues. And our own data show that we actually serve quite a wide demographic, and in order to reach a more vulnerable sort of minoritized group of people, we maintain outreach services. And despite the fact that there is a challenge, both from a workforce and income perspective, I'm just going to sort of highlight a couple of things that we do. So we provide sort of implants and intrauterine devices for the women in the postnatal ward, because we're next to the acute trust, but it's a really easy thing to do. Across the way in West London, we support a charity, mostly South Asian men, sex with men. What we do there is provide HIV point of care testing, counsel them around accessing HIV pre-exposure prophylaxis and prevention services, and also a lot of work's being done around the Latin American community, accessing Vogue clubs, again, increasing PAP awareness. So this is post-exposure prophylaxis awareness amongst that. So, I mean, I think we do quite a lot of good work, and we're really proud of what we do. But I think, and we've innovated and trained and done a lot of research around it. But I think there's also a lot of things to be sort of worried about. And I felt very sad reading an email yesterday from a consultant colleague in a clinic in Southwest London whose budget is being cut mainly through staff cuts, clinic opening hours being reduced to cessation of vital complex contraceptive services as well as psychosexual services, potentially displacing service users there to neighbouring boroughs. more importantly, these cuts are going to, unlikely end up in unintended pregnancies and increase health inequalities in those who can't afford to access psychosexual services privately. For example, those who have experienced sexual trauma, and it will waste more resources in the long term when these individuals do present to GPs, gynecology, urology. These services cannot help them. So it is really, really difficult from that perspective. And I think we're trying to align as best as possible kind of requirements of the service needs locally and also nationally. I know we know that there is a London-wide and a UK-wide crisis. Services are on the brink of collapse in some places, and it's really important to recognise that because we're open access, so the decisions in one borough may affect or impact the whole of London, sometimes even wider. And so I think we're all working trying to get an approach that makes us more resilient, and also being able to save cost, getting the right IT systems, digital resources, pathology, and getting a strategy so that the workforce that are there we can future-proof, so that these precious staff required to deliver the quality services, we're going to be at grave risk of losing them through continued cuts to the services. I'd be really interested to hear as well how we can work together, how can we invest in a wider service so that we're not left behind. As the councillor Renda was alluding to earlier, we met a few weeks ago with one of our very passionate nurse practitioners is working on the outreach work that she's doing at the minute, which is wholly unfunded. But there's a lot of interest in really reaching the people that we need to reach with unmet needs. So when we say unmet needs, these are the population, asylum seekers, social workers, minoritized groups. We've done a lot of work in the last 6 to 12 months with these pockets that are within the borough, in and North West London, as well as very, very, a lot of them are represented by the borough residents themselves, RBKC, but also at the same time to ensure they're all appropriately remunerated. But I really believe that we can to keep these conversations running. If we could, have further dialogue with themselves, chair councillors, around the table, commissioners, to review what is going to be in there in the forward plan that comes through, so that I think to have some sort of representation within that budget through at least outreach work that we can help these groups with. This is only a small part of it, but I have to do this.
Thank you for your honesty there too. And I mean, I know how well regarded and well renowned your services, so from others, but also picked up on the paper. I was just going to start by asking you about the e-services and just to understand a bit more about them. As I know they're very cost effective, but just if they are to be growingly used, are they suitable for all patients? And does that mean that there's going to be other forms of the service that will be taken away? Just to understand if it will still kind of have options as to what people choose to use, or if it's going to make up much more of the service. That's why I'm going to start by asking you.
I think it's really important that it exists, and it continues to sort of reach people otherwise who may not engage in services like this. But of course, sometimes it misses the point. I think it's quite easy for people to go, "Oh, let me just get on this with this kit so that I don't have to attend the clinic." But for example, if that particular person is a man of sex with men that has other risks, they're then missing the opportunity to come into a physical space to get their vaccinations, HPV, hepatitis A and B, and so forth. And so that becomes a problem. And so we feel that the services are excellent, that they do exist, and they help a lot of people. But unfortunately, of course, then when we're talking about patients who access online services, they are labeled as asymptomatic. So they are channel shifted across, but not every asymptomatic is simple. Some of them have complex safeguarding needs that they may not actually want to disclose even online. And so there's a lot of work that has been done that work on the inside of the service, because we're also looking after the clinical governance of the e-services. And we found that there's a lot of safeguarding issues that don't get disclosed, and then find out much later on that these things are missed out. So on the whole, absolutely, it's a really great service, and I think it should be there, but there should be ways of really finding and targeting people that need to be seen in a physical space. That can't be sort of it's underestimated, and what you going to add to that?
Oh yeah, I just wanted to say that I think we issue about, SHL issue about 6,000 tests a day. And 80% of the people who are using SHL are return users. So we've done a lot of work over the years. HLT in Westminster do the governance part of it. So all of the positive results of the safeguarding alerts sits outside of John Hunter Clinic, but within the directorate. So there's a lot of work to channel shift, and I think a lot of the sort of easy asymptomatic, the sort of people who won't well, and everybody who wants to just sort of keep on top of their sexual health have shifted, which has left a lot more complexity in clinics, and still the sort of other groups to meet. And maybe also either indicates that the move's being done, or does it, and actually we need to go further afield and with it just kind of reach the plateau with the new.
And then,
Councillor, just to your point, I think there always has to be more than one way of accessing services.
Yeah.
And while we are striving to make it as accessible as possible through services, there's no doubt that that's a benefit. Through a clinical governance structure, you have to have the other models, and we will never only have one form of booking in.
Yeah.
And in fact, more widely, I think this whole process and recommissioning the review of services that the report recommends ultimately is going to look at that balance, isn't it? What's the balance between the core process and a VFM approach, and what do pockets of the population where we know we have targeted requirements, what do they really need? And I think all of our work is about striving for that balance.
thank you. I'm just going to ask one more question, and then I'll start Bosha, because I think you'll probably want to ask after. But the one thing I was going to ask you, and I know you spoke about how these services are in south of the borough, and there was a kind of lack of not a huge amount in here about GPs, but I know that that's because we're not providing a huge amount of sexual health services through GPs, and you note that the sort of updated LARC is sort of significantly low, I think, since COVID. Is there, in terms of what you're worried about with budgets, gaps, and maybe not the right funding going forwards, and what you're concerned about, is there, if we were working closer with GPs and providing some of those services, would that take concern off you in terms of looking forward in the future, if not only were those services spread more around the borough and more GPs were delivering sexual health services, but that was kind of relieving you of the stress of your, I don't know if that would help your budget stresses, but I mean, I think that's one concern that I know Portia brought up is that the presence of the North isn't there, and how we can develop that if people don't want to be travelling to south, or if they choose that they want to be going into their GP for those appointments, which some may not either, but kind of how we look forward as to how that can not only maybe help you in terms of looking forward, but also spread services around the borough. Interested to hear both of your thoughts on that.
Well, I can talk a little bit about Hounslow. So we also run our services out in Hounslow, and the Hounslow Commission, so the commissioned us to do an integrated sexual health integrated sexual health contract. So we actually do work with GPs and pharmacies to deliver a certain amount of testing, but then to deliver a certain amount of testing and LARC. It has been actually quite difficult. We've seen that the GPs and the pharmacies have not necessarily wanted to take it up. I think there's still some stigma around the conversations. I think some patients maybe don't want some of the sexual health stuff on, well, you have to have them on separate systems, but don't necessarily want to go to the GP for that, because they might see somebody, of course. I think the GPs work well with LARC, but I think also GPs are under massive stress at the minute. So in some ways, it's like, can we help you? Taking off some of that of that work. I think there is an area of even delivering it there, getting out, outreach, delivering it in the GP services. All of them, I'm just, thinking, but I think with the testing and the sexual health advice, what we found in Hounslow is the GPs want to be able to refer into us. So if someone attends with something, relating to their sexual health, and I don't just mean chlamydia, I mean, psychosex stuff or anything outside of that, they want to be able to refer directly into us. So it's a conversation that with the whole system.
2 points: a huge amount of the testing capabilities very centralised around the diagnostics. And then the second one, I think the report actually says that over 90% of the borough's needs are met within the borough.
Yeah.
That's really high comparatively across London. So I mean, I accept absolutely not everyone wants to travel around there, but comparatively, I think you're in a good place for access. You know, if we look at some of our other services, that's not the case. Thank you.
Thank you, Chair. Thank you for a very interesting and important report. I just wanted to know what percentage of your service is outreach based? What percentage of your service is outreach based? When did you realize that there was an high increase in STI of that age bracket? And what will be done differently to lower the rate of STI in the borough? What measures will be put in place? Because this is very important. What support will be given to the north of the borough?
So in terms of an actual percentage, I mean, a lot of the outreach work that's currently coming out of John Hunter is very ad hoc because it's all done sort of outside hours and goodwill of the practitioners that are involved. So within in North West London, I think it's quite different. So we have Fulham do something different, and some other clinics, and we have different sort of arrangements. So in our case, we have quite a few established sort of lines of outreach work. So one of them is a support for sex workers. It's called Swish Clinic, Stash Clinic, and that's and Slog clinics running out of Earl's Court. But I can't give you exact percentages of that, but I can certainly get back to you if you were looking for percentage exactly. But we are trying to enhance the provision there, because there is so much that we could still do to go to asylum seeker hotels, to go to schools, and we're already going to schools to give sexual health education and work with minoritized communities, and not to forget about under 18s that we see a whole load of. So, for example, in the last even 12 months, we've seen over 4,500 individuals under the age of 25, and 330 of those were from the inner Northwest London boroughs themselves. And so it's quite a great proportion that we do see, and we want to make that. Offers of service a little bit wider. We want it to go a bit wider. We don't want that to be forgotten about. And it is, I mean, how just wouldn't mind repeating the second bits of the question that you had.
When did you realize that there was a higher rate of STI in the borough?
Oh, I think we always know. I don't think there was ever a time there was a low rate of STI.
We monitor our rates through our results. We have it's called Gumbis, but it's essentially a dashboard with all of our information on. So we always know, but what we also obviously look at is all of the sort of national or London or borough-based public statistics. So we know that at the minute, you know, across London and across, there's a higher rate of bacterial STIs. I think it's interesting. What we don't have at the minute is the exact sort of correlation between, but the rise in the use of PrEP is definitely being in parallel with the rise of STIs. Now, obviously, not everybody with the bacterial STI is like a GP-MSM, but you know, we were just sort of met the Minister for Public Health yesterday, and we were discussing, he was saying the same, we were discussing that actually, you know, we wonder if actually the campaigns and the education needs to be around now. You know, yes, we've got the HIV diagnosis is driven down and we're protected against HIV through the increased use of PrEP, which is absolutely fantastic, but the other bacterial STIs are still at risk. So that's was what we're going to do about it, is we want to enhance our outreach offering. We want to mirror some work we do in Hounslow and Thumb and Dean Street, and we want to do it very locally to what the borough needs, as Gurmit said. And we also want to look at sort of campaigns. We run campaigns in Hounslow. They give us a budget to do it, but that's not what I'm here to talk about now, budget-wise. And actually, I think that's something we need.
I was just going to say, from what you said, Portia, just to bring in Josh and Gareth, is sort of what we're doing as a local authority in terms of the comms side of what Portia just raised as to, you know, educational campaigns.
Yes, we've got Anna here as well from Public Health, maybe. Maybe better on that front. No, it's right. And Portia raises a really good question, as always, Portia always does, on this issue and others as well. And I think, obviously, part of the council's role, especially the public health role, is to encourage comms, communication around a position where people can access help where they need to. but also kind of have a bit of a preventative measure as well on that too. Obviously, as colleagues here have mentioned, I think some parts of sexual health care and treatments do have still a stigma as well across many communities, not one over the other. But that's something that we need to obviously encourage and do that as well. Obviously, we do have a program to try and promote services that are provided as well. But I'll bring Anna in and Anna from a more professional point of view to fill in the details.
Gareth wants to come in as well.
Sure.
So in the paper, particularly, I think you'll see reference to SASH, which is our preventative sexual health service. So as well as the specialist clinical sexual health service, we also commission from Turning Point a prevention service, which does a whole host of outreach in the community, targets specific groups who perhaps have been marginalised, like people with learning disabilities, etc. And they do a lot of outreach work in the community. They also work alongside our local schools. So we perhaps differ from some of the other boroughs in that we have two arms to our sexual health service and our offer. And perhaps we should have cited SASH here tonight, but that's a bit of an oversight and something we'll look to do in future. I certainly agree around the changing messages around sexual health, and that's very interesting, the conversation you had with the Minister with regard to perhaps an impact of that means that we need to be thinking differently around those messages. Not so similar to where we were with contraception a few years ago around the importance of barrier methods alongside other methods and maintaining those messages out into our population. So that's something I look to explore further across London and wider. Do you want to come over?
Only briefly, I was going to, you mentioned the point about SASH as our commissioned outreach service by Turning Point. So we do have that service, but it's unlike the example that's given with Hounslow, it's not delivered by the same organisations as that training service. And so there are things we can look at, I think, in future as we come into recommissioning the sexual health services about how we can connect with them. The other point I just wanted to make, picking up some of the conversation there, is as we come to recommission services locally, given the increase in uptake of the service, as well as what that means in terms of the numbers of positive cases that we get, it's the complexity of cases that then come into the clinic. And the way that the sexual health commissioning works at the moment is based on a tariff system. So there are tariffs that the kind of clinics pay per type of activity, and yet those more complex activities don't fit within the tariff structure. And I think that's partly the point that kind of Jeremy was making, is that as the clinics themselves are picking up more with complex cases, but the more repeat straightforward cases are being served through these services. And it's probably something to think about as London, because that tariff structure is a London-wide one, about how we support these services to operate more in that complex world in terms of outreach, safeguarding, dealing with less complex cases.
I'm really sorry.
Yeah, just let me just say this. We're all aware that there's only Chelsea and Westminster as a face-to-face and St Mary's Hospital for one-to-one face-to-face presence. Now, what is going to be done for the north of the borough, considering the trauma that's been there, mental ill health people, patients, they're very reluctant to go and face their challenges or their issues or their health problems. I mean, what front door is going to be available for those in the north of the borough?
I think to reiterate the point that's been made before, and it's in the report, which is it's very common for people accessing sexual health services not to want to access them in their immediate neighbourhood, but to want to go somewhere else. They don't want to necessarily see their regular GP or to go somewhere in the community. And the evidence seems to be borne out by access to that services, which is they're really well used, not just by people from within our borough in the north of the borough, but from all over London and other parts of the country. So whilst I think in terms of accessing the people in the high risk groups, not in north of the borough, making sure they're accessing the services, that can be improved, I think, in terms of how we look at the way we do outreach in the future. The actual location of the clinics, I don't think is necessarily the issue.
I think so. What if they don't have any money to travel to St. Mary's or Chelsea and Westminster?
That's what you meant by sort of delivering it out.
I think what you mentioned about outreach is very important.
Yes.
Yes, but I also think there should be a front door building presence in the north of the borough, even if it's for a one-to-one basis to actually give them literature, to let them understand what's going on in their body. Also, to refer them to treatment, to let them understand. I really think so. How long does it take from north of the borough to get to Chelsea and Westminster or St. Mary's? What is it? How do you get admitted into St. Mary's? Do you have to call them? Do you have to make an appointment? How long is that queue? Is it a first come, first serve?
For sexual health.
Yeah.
They have a
Sexual health is
online. Yeah, so after they book online and then I think there might be a couple of days where we don't directly with St. Mary's, obviously it's run by Imperial, although we work very closely with them.
Yeah, but within 24 to 48 hours, an individual can definitely get an appointment within on phone or booking it online. So the access is absolutely there. But I get your point. I suppose if there's no physical presence of a space for the borough, for the residents in North West London, it's difficult because if they're already so vulnerable, and if we're talking about people in homeless shelters or prisons, you're absolutely right. Where we've got to have a presence there. That's the first thing. Before thinking about, I suppose, space that's also there for them instead of clinic popping up there. But that needs to be what, and I completely get your point. We've also seen quite a few looked after children under 18s coming from that part of the borough, which is it's difficult. These are population that will not come forward. These are populations you need to look for because they don't perceive themselves as taking risks. So I think that's where we need to really get our outreach sort of hat on and actually make some good links in the borough in the first instance, because I don't know about physical space.
Do you want to, and then I'm gonna move
To comment one to that, I think the outreach point's been well made, acceptable. So, in other areas, there are growing roles for primary care network hubs. As a local area, it probably isn't going to be a sexual health specific issue, but it might be something about the whole wider preventative agenda, full stop. And it may well be some economy of scale in that sphere. And there are other areas of London beginning to think about that for precisely the reasons Councillor Fay is sort of setting out. I was wondering if it was the one point that Gareth was making, it was being alluded to earlier. Where elsewhere in London there are, for whatever reason, changes in the consequences, we are expecting, as a result of the changes in Wandsworth, some of the access issues, some of their patients start going. So it's very easy for them to go, relatively easy to come across the road to Chelsea, Westminster, and John Hunter. And for us then to think about what does that do for our overall impact around that. And so we'll continue. I think the review you're looking at is going to want to make sure that the quality standards are being maintained and those access standards are being maintained. And it's our responsibility to make that dialogue with you, the way the government has said, to make sure that you as commissioners are aware of that kind of, the elasticity, if you like, of the London picture. And it comes back to what I was saying about balance, really. We just got to find, you spent £3.1 million through there. How much of that do you want, like the core VFM processes in each services are more weighted to making more straightforward things? And how much of that to be targeted at either specific issues or specific inequalities in populations? I don't think we probably ever get that right in terms of that balance, but if we've got that dialogue about what we're trying to achieve together, I think we'll be a much better show.
Thank you. And go round and then one and then.
Thanks, Lucy. I actually just wanted to go back to Lucy's first point, actually, because it seems as though the e-services and the online sampling, that it seems as though that's the direction of travel given its cost efficiency, which is understandable. But I guess it's worrying because those groups that are going to be bearing the disproportionate burden of sexual ill health are the very ones who are less likely to be wanting to access or able to access the online services. So you mentioned, Gareth, that there's an improved or increased uptake when it comes to the e-sampling, but actually we know that the increased uptake comes from specific groups, specific demographics, people who are of white ethnicity, from more affluent, less deprived backgrounds. And those people who aren't from those groups, who actually, bearing a much bigger burden of sexual ill health, are the ones who are less likely to access the e-sampling. And it's just really worrying because of the impact that that's going to have on health inequalities. And we're in Kensington and Chelsea, so that's always at the forefront of our minds, or it should be. So I just want to understand what investment will be happening alongside that of the outreach services, because it's not acceptable that it's running on the goodwill of staff, although that's not uncommon at all. Just wanted to understand what investment's going to happen in outreach, so to target those groups who actually need it, who are going to be missed with this new type of identification that we're going to be using more and more of.
Shall I first go about what we're doing about some of the monitoring? So as of this year, there's a new duty of trusts to report against inequality aspects. So we've been monitoring the system that has been before. We've got a formal statutory duty now to report against and analyse all aspects of inequalities, both from the protected characteristics all the way through some associated and wide demographic ones. So I think we'll be much more sensitive to the variation in access, the variation in outcomes, and what to for that. And that dialogue, I know you've got your own data on some of those, but by quarter we can start to look at some of the impact of that. So some of the trends that you're talking about, which I think intuitively is going to happen, if not already happening, I think will be much more visible to us much more quickly. And in my view, will be the platform for us either internally, in terms of use of the contract, to target outreach specific action or community sensitive action, dialogue with Primary Care Hubs if necessary, or in dialogue with the Commissioner about some targeted work. So I think we're much more able and much more set up to have a data-led approach to this, and to therefore to target investment against some specific issues and give ourselves some measurables. In terms of exactly what we're doing, there are some initiatives around that, but I think that's exactly what I'd be looking for from the review which you're commissioning, which is what are the objectives you want to see? How can we sort of put that in place? What's a reasonable use of the investment to do that? And then we need to publish the results for you. So it's a plan for a plan rather than an answer, but I think we're much better able to start getting at that data and start saying, right, what is it we need? Where are the problems?
And you're saying that there's capacity then to do that sort of more targeted outreach work for those groups that are being missed?
I think it depends on what the answer is. But from our perspective, I think that the service has continually shown, as a trust corporate director of the trust, the service has continually shown the ability to essentially reinvent itself the whole time to take forward the next aspects. Think about Dean Street as an example. We have a huge number of walk-in patients with it, but then alongside that, there are a whole series of practitioner-led, more complex type work. And over the road, there is a series of patients. So I think as we have a track record of being able to respond to the variation in need and demand.
Just to clarify, we don't have a huge number of walk-in patients at Dean Street, and that's a point of contention. No, only prep staffs and under 18. But we have some walk-in ability, I wanted to say earlier, obviously, for anyone who's vulnerable, PrEP or sexual assault under 18, or somebody you attend to, we need to see they can walk in. So not everybody has to wait 2 days on the board.
I mean, that does sound quite reassuring, what you've mentioned. It would be really helpful to have the kind of the specifics of what that additional outreach targeted stuff might look like, because there's quite a lot of data already to kind of point to which direction things are going to go in terms of who's going to be missed and who is going to be uptaking these services. So,
I mean, away from the arena of sexual health, as a trust, we are increasingly recognising that unless we are supporting wider improvements in overall population health, we're missing the point. And so, that traditionally has been symptoms at the point of access, and we're focusing on that sort of thing. It's much more holistic, I think, now, and At our clinical summit last year, I think the view from the floor from our operating clinicians is of course we're interested in diabetes or respiratory infection or whatever the subspecialty issues, but unless we're identifying addressing unwarranted variation in population, we're not providing a quality service. And while we're in the infancy of that, culturally, and in terms of clinical analytics, we're trying to set up to respond to that.
Thank you, and thank you for this report. And I know how sort of renowned your service is, so that's excellent. And just reading on to paragraph 516, just really trying to understand why in Cairns you have that particular high rate in comparison to the rest of the country, and what does that mean going forward in terms of recommissioning and where priorities go and how we address that.
Yeah, so sorry, so the query is the STI rates excluding committee on the age of 25, why they're higher than the national average, and looking to see why they're higher than the average.
Why they're higher and what that means for recommissioning. Yes.
Yeah.
I think that's not new. That's the comparison with the England averages. And so in London averages have generally always been higher in terms of our rates. The kind of diversity of our population, particularly in the north of the boroughs, as is set out in the report, means that there are some groups in the borough that are higher risk than you would see in other parts of the country. So if you took this chart and plotted against it, not only Kensington and Chelsea, but other boroughs in inner London in particular, compared with the English average, they would be along the same lines, us and sometimes higher. So that's more a feature of where we are in London compared to England rather than something particularly has changed in Kensington and Chelsea. But in terms of then the things that we're doing to address that, one of the things I was just going to come back on the last question, which I need to build on some of the points that have already been made around making better use of the sharper data that's now available in terms of the more at-risk groups. Is I think it's important to make the point that we're not spending any less money, but the success of some of the e-services for particular cohorts creates an opportunity for us to think about how we kind of best reconfigure and allocate the other resources to make sure that they are still delivering those kind of exceptionally high quality services, but where possible, configured to be able to deal with some of the more complex cases and to do some of the outreach that we've been talking about, or the parts of the borough that more at-risk groups are. The SASH service that we mentioned earlier isn't like a clinical outreach service in that sense. It's an information, advice, and education service, critical in terms of the prevention message that we've been discussing. But what we're learning, as Dominic and others have described, is that there are certain groups in the borough, certain neighbourhoods within the borough, where a clinical outreach service intervention might benefit more, and the success, if you like, of the spend we have in total so far, and some of the areas of that means that there's an opportunity for us as part of this recommissioning review to think about how we create space that we with the money now.
Part of the challenge we have in the context of the commissioning structure for sexual health is making the case for our population and our services within the context of wider London, and the fact that we draw in a lot of the complex cases across London and nationally, which has implications for us. So whilst other areas like Wandsworth or other parts may be able to make decisions about their sexual health services, particularly perhaps to find savings within a system, it's much more challenging for us. Part of the conversation we're having at the moment is really saying to the rest of London there needs to be some recognition of the difference in demographic, the difference in need in our population versus the rest of London when looking at the parts of the system that are going to be commissioned across.
Yeah, because as the report says,
And these services are very popular, very successful, and so much so that of the numbers that are seen in the Shuttleworth service across inner North West London, 30% of them are inner North West London residents, and 7% of them are Kensington and Chelsea residents. So the vast majority of the work isn't Kensington and Chelsea residents. And so the complexity of that in terms of the commissioning and recharging measures with our partners something that takes quite a lot of resources and time. And where it's actually focusing on the needs, that's something that's in a different place. This is something that we've got an opportunity to look at.
Second.
Thank you, Chair, and thank you for your report. I have a question regarding the abortion level in comparison with the STI level, actually, because what I found interesting is the STI level in Borough is, as we've just said, higher than the national average, but what paragraph 520 seems to imply is that, well, actually saying, is that abortions, especially among the younger population, is actually lower than the national average. Is it a new phenomenon, or is it something that's always been the case? And if so, how do you explain the difference between the STI being much higher, but the abortion level being lower? So obviously men having sex with other men cannot fall pregnant. So that would be, off the chart. But is the difference justified? In other terms, is LARC prescription working better than sexual disease prophylactic prescription?
And so LARC prescription is really quite good within the borough,
Clearly, yes.
clearly, and that's worked out quite well. So in terms of prophylactic STI provision, we at the moment don't provide. So in that case, you mean slightly and post-exposure prophylactic is not exactly commissioned as such, or agreed nationally. It's not something that's provided. But it's interesting because, we still have the STI rates being really, really high, and patients coming in and perhaps some of these patients that come in who had the abortion is probably in excess of services. Some of our services were not providing the abortion services as well. So these are another things that are quite separate. So it's very difficult to look at all these patients who access the abortion service, did they also go to the sexual health clinic? Were they the same patients? How many of those patients were forming the demographic that we saw that gave rise to those figures that we're seeing in the high syphilis and gonorrhea figures. So that's difficult to actually look at. I think we provide across, not only across the borough of in North West London, but also having arrangements through to Wimbledon, Wandsworth, and to provide a LARC service for the residents and those boroughs, just because we have the expertise, we have the teaching and training expertise, and we've got the facilities on board. So in that sense, that sort of reduces the number of abortions.
But is there any learning from that capacities that you can reapply to STI prevention? And because clearly this has been working.
Yeah,
and so why in the STI number is still still higher than the national average, while the abortion is lower? Because it's the same place, I appreciate it's not always the same populations, but there is an overlap.
I think it's looking very specifically at patient behaviour, isn't it? I think one of the public health campaigns England have seen is reducing, unwanted pregnancies years back, and it's sort of maintained. And I think a lot of work went into STI prevention, and I do think it would be interesting to look at, as I said earlier, the correlation between the PrEP usage and STI usage. It's not just NSN, but I do think, we were talking about this yesterday, and this is sort of almost anecdotal, but is it, STIs outside of HIV are treatable? It's an antibiotic, it's an injection. A lot of them, syphilis. And I think it's about the attitudes. I think it's, the attitudes of people, maybe if they've got that in mind. So I think there's a lot to learn about what happens in reducing unwanted pregnancies and reducing STIs.
And also to say, patients who do turn up for abortion in services may not provide the STI testing in those particular sort of services, and that's where they might miss. You might miss actually them forming part of the figures. So the abortion services don't sit within the sexual health exist elsewhere. So they don't provide all the other prevention tools that should really provide information who are coming to access abortions, and that is really difficult. So again, it's about identifying, are these people also needing further testing? Absolutely. Or have they just got lucky? We don't have that data because we know that, falling pregnant is one thing, but you might have been lucky that you were 150% that maybe you were exposed to chlamydia gonorrhea and didn't actually contract it or get it. But you're absolutely right, they don't provide it in the same space, which is why the data might be missing for that particular group population that you're asking about.
What we want to do in Chelsea and Westminster is concentrate on a women's hub. Now, obviously, we need to get the terminology correct, but a hub where you can access everything. So almost from birth or unwanted pregnancy to menopause. Now, obviously, the local authorities commission sexual health, so I'm not, that's where there's the stop and start bit. But we can do it. We can provide something which is much more integrated. And we want to do it at Westminster and John Hunter because we're out there, the two sites where we've got access to gynae, we've got access to other clinicians and services as well. And I think it's something that's in our strategy that will hopefully be.
Thank you, Chairman. Just quickly on a couple of questions really about data. Just following up from Councillor Pettitt's question. It's the average that we have lower. The lower proportion in England is repeat abortions. Do we have data on overall number of abortions? Do we know if we're also lower than the average across England, or?
So we haven't looked at that for this. So repeat abortions is used particularly as an indicator, which gives some insight into the impact of services, which is why it was included here. So we haven't specifically looked for the purpose of this report at abortion figures, but we can check that actually.
Thank you for clarifying. And then just on the graph above, that number and that rate of STI, which is higher than RBQC than from the rest of the country, are these numbers number of people that come to you, or are they people that actually live in the borough?
The latter.
The latter people that actually live in the borough rather than the actual numbers.
Yes, it could have been diagnosed elsewhere.
Okay.
The analysis would indicate that about 90% did others.
Right. And so just to follow up on, I think, the line of questioning that Councillor Hargreaves sort of raised earlier. I mean, what essentially is, as you say, we've known for a long time that rate is higher in inner London. I mean, I think that's demographic. I don't know if you're pointing more to age or diversity of ethnic population or that. What sort of, I mean, fine, we've known that for a long time, but what work is being done to try and mitigate that? I mean, I think, it's sort of slightly unsatisfactory state of affairs, like for us to say fine rates are higher in inner London. We see that across the board. I think all of us would probably like to see that, some sort of strategy or plan or attempt to, if we can work out why that is, then to work to try and mitigate that and reduce that rather than just.
I won't speak on my colleagues who are medicine trained, but from what I do know, Councillor, there are various reasons why that's the case. Obviously, Central London, as we've said before, many people come to use the services here for that as well. Big diverse population. We've got a lot of people who are visitors that come in as well. That
they wouldn't be in that.
No, the residents as well. We may have taken sexual relations with people like people visiting as well. Obviously, we have sex workers as well in the borough. Who obviously are more at risk for that, and of course, being in Central London, we're going to have a higher rate than someone in a village in the countryside, in that respect as well. But also, like our colleagues as well before, I think too is that with the availability of things such as PrEP now, I just reiterate that people are more confident perhaps in their relations, and not necessarily worrying about, since they think that can't catch HIV, so therefore I'm just going to go for it effectively. But that obviously exposes people more risk to other STIs, which hence may be reflected in these rates as well at the same time. And plus we have a transient population too. So a lot of people come in, a lot of people come out, so visitors, and we have asylum seeker hotels. We've got a wide range of demographics here that perhaps aren't reflected in the rest of the entire country, except perhaps other big cities like Manchester, etc. But overall, that's probably why they are like that, what I'm aware of.
But my understanding is that they've been higher for a lot longer, right? So the asylum seeker hotel is relatively new. Right, and a number of the other things there are relatively new. If we're looking back 10, 20 years, presumably, I don't know how far the data goes back, but presumably we were just as high then. Right, we assumed that Central London was higher.
These are hypotheses, aren't they, rather than I'm going to set out, but it's also not just within sexual health, but with other risky behaviours. I don't think the young population is undoubtedly truly good younger population, but this graph is an under 25 comparison, so that's factored in already. And so I think it's undoubtedly true that the diversity and the mobility of the younger population, I think, is possibly an issue about that. But it kind of goes back to Councillor Harmer's point. We need to get into the granularity of state and start looking at the actual location of people, where are the pockets of things around that. And I think potentially all in health and care more generally have gone on breadth, have gone down volume, have gone down or first dimension service, and you've not addressed the point you're making, which is also historically high rates. We've got historically high rates of access schools stop, so we're busy. Up in rates, I don't think we're addressing the kind of problem.
On this data, just quickly, we move on from it. Is there any breakdown, or do you have any understanding of the ages that we're talking about, young people, or are we talking about?
But we've got a whole length of
No,
I think we've
This is excluding chlamydia under
Excluding
25. but
excluding-
rest-
Oh, so
I don't think it's under 25.
so in which case, what about the younger population? Sure, I apologise.
But what I would say, and I would hold my hand up for, the England comparator actually isn't that useful. I think it's given you a context of sort of STIs nationally. I think when we're looking to understand rates of STIs and understanding how we fit, the London comparative would be much more helpful.
Yes, yeah.
So, I would share the London comparator with you, as apologies for something I should do.
At least we're comparing more like with like there, aren't we, than with the rest of the country.
Yes, just keep saying conscious of our time.
Yeah, just give one instance that actually links to the next agenda item on substance misuse, which is where getting into the detail of this data, and as what we said, is something we do more of, but it's not something that's demonstrable. And so where information and understanding about high risk groups and the services that we can use that are specialists are available. We have in the past and continue to commission special services. One of the services that will come up in the next paper is a specialist blood trial clinic. So for largely for going for sexual matters, men who are at high risk of substance misuse, but also contracting venous infections. We have commissioned the only one in the country here in Westminster specialist blood clinic, and that provides a service for those people and has an outreach staff in the industry and sexual health. So where we know that in this data there are particular groups that are at higher risk than others, we have on the past and can continue to commission specialists.
I actually don't have any further questions. Something else.
We'll start with you next.
I did want to thank you for coming. It's been a really interesting and useful discussion. This isn't something that I've known very much about, so it's been really useful to hear you speak about this. So,
And for us, not just about sexual health, because actually the recommissioning of services is an interest in the team tonight and begin that debate and discussion. But as a trust, as I said, we are at the foothills getting into population health. This is a kind of an exemplar where we've got some analysis and sort of background that. If we were talking about other services, we'd be way behind in terms of our understanding and our approach to population. So it's actually a good lesson learned for us in terms of other services.
I also have one more question, which before we bring you in, Josh, which was just around kind of the comms that you have in place, if there are comms in place to kind of be messaging people to remind them of the appointments, or just because I know that as sort of stigma attached to STIs and people would prefer to just push all of it quite often out of their head, but that kind of is there a kind of way that we're communicating to patients who either attend you or as a local authority just to kind of have those check-ins to remind them that actually it's normal to go for checkups every now and then and yeah, just sorry to add that to our huge bunch of questions, but
No, I was going to say, Chair, as well, that it would be helpful, I think, as we're obviously going to recommission sexual health services, particularly to pick up points and recommend to us, to Gareth and myself, bits that work, bits that you would like to see, obviously, colleagues here as well, adding into that, which we've done already on that, so you get the best, and that may be one of them. I don't know, but obviously the community to scrutinise and to recommend myself and colleagues as well what the best way forward is. So perhaps that's probably one of those things as well. Obviously, we can look into that. Obviously, there are, you know, human rules, commissioning rules, budgetary pressures as well. But obviously open to see what the community may recommend on what the council can do on that.
it'd be interesting to just kind of see if there's something you send us, but what is, in terms of that kind of comm strategy from the council, what we actually are doing already, or and understanding what we could be doing, because I think that prevention side is incredibly important, and that's what's going to help.
Yeah, perhaps we can get back to your writing on that, on the specifics around comms from the council perspective anyway, on textual that.
Yeah, we did it digitally a lot.
Yeah, because GPs, I mean, my GP texts you whenever you need, and it texts you when it reminds, but not everyone does that, and I think it is a very good way of just communicating and reminding people.
It's really interesting that you asked that question, because a lot of patients that come to me in the clinic with sticking injury, trying to divide them, they're like, oh, surely I'm going to hear from the clinic in 8 years' time when my marina collects five. I'm like, no, you won't. But so that's kind of got us thinking, let's actually do this piece of work and actually send the reminders.
Yes, and with that, it comes up with a kind of website link where you go and you book your appointment, because that is making it as simple and as easy as possible.
Well, we push our messages to our high-risk patients at Dame Street a lot, and I think it's something that, you know, we are in the process of defining and developing in line with the work we're doing, isn't just our outreach, to say the word again, but also population health strategy, and it's how we learn in different pockets from the work that goes on in other pockets.
So monkeypox would be a good example.
In
terms of the.
And I mean, I again stress, I do think working with, I know it's GPs that incredibly push the time at the moment, but I think having those services when it's dark services and training more GPs would also be great. I know that there were a couple of asks, one came from Mana, you wanted some specific data on additional outreach.
Yeah, so if the data comes back that it is in fact the case that certain specific demographics are missed from the sampling stuff, the mechanisms of how that outreach is going to happen to kind of remedy it, that'd be helpful.
And then was someone asking for the figures on repeat abortion figures?
First time abortion,
Okay, that was pretty interesting. And then I had a couple of recommendations for us.
And the London
data.
Yeah, just very quickly on, I think I forgot a couple of, sorry, apologies for this. Is any data kept on the sort of repeat STIs? Is it what people who are coming back having already had an STI? That would be interesting to see as well, and how that rotates.
There is. Out to be a report released, isn't there, on the impact of B-side assets in London, and that's being written up, so and it will include a lot of that.
Sorry, Chair, can I just say as well that I've just looked at the footnotes on page 14, and the table is actually provided as the IPA, where it says the 9 files to England. It's actually available in the report, but I'll circulate it on page 4.
That would be great. And then just a couple of recommendations for us to consider at the leadership team. One was to step up communications, outreach and engagement with our communities and high-risk groups such as young adults to improve prevention. And the second was to consider the issue of digital exclusion experienced by some NHS patients. What's happened to create those? Thank you so much for coming.
Thank you. Thank you for having us. And if you haven't already, Mr. John, it won't be.
Let's
Always still there.
In London.
Yeah.
Substance misuse services. This report provides an overview of substance misuse services commissioned by the council and update development, the Kensington Chelsea substance misuse strategy. We have Josh here, Josh Bendel is today, the lead member, and Karen and Anna Hardy. So it's an RT report, and yes, I'm sure you're aware we went to Turning Point.
Yes. Thank you, Chair. Yes, so obviously, again, one of our commission services is a substance misuse program. It's great that yourself as the community went to visit one of our sites, which is Acorn Hall in North Kensington, which is provided by Turning Point. We also have our other services based in Redcliffe Gardens and that's what I was called, which I know Councillor Wade is here, perhaps wants to contribute at some point to this. Of course, substance misuse is really difficult for people, obviously people with addictions. And on my visits to Turning Point as well, it was really interesting to see kind of the work that they do, the outreach work they do, but also have kind of a community focus at the same time to get people who are suffering from substance misuse to come, obviously meet others in similar situations, but also encourage kind of a wider work as well. So when I went to visit, I saw their outreach program, how they get the service users together, speak about their experiences or how their week has been even. They run a little food bank there as well. It's really positive, obviously healthy eating, encouraging people to do that at the same time. And kind of the success of the program and how Turning Point in North Kensington has had an impact on the community there. And obviously people are appreciative of who are victims of substance misuse and how they can overcome their addictions. The community spirit that it raises as well. So much so that the former public health minister came to Turning Point with the former MP to see how we provide it as a service at RBKC as well. And we had ODID there as well, and Anna too, promoting that service that we have. And of course, there are always going to be people with substance misuse unfortunately, but the best what we can do is provide them the best services that we possibly can. And I think what we've done through Turning Point and other colleagues, made an impact. I think the report says that we actually have an increase of people using the service, which is really positive, because we're actually doing it in the community and encouraging people to come and use it. There's not trying to break down the stigma. So if you do have a problem, you can always seek help, and I think that's really positive. Especially in Earls Court, I think we've got an increase in Earls Court of people using the services to help them out as best as possible. But as you say, I won't go all over in the report as well, but obviously just inviting the committee to have views, what the future direction of travel may be, etc., to what we can do better perhaps.
And yeah, I think we felt very moved by hearing about the service, and yeah, I think we're very happy to
Thank you, Lucy. And thanks, Josh, and thanks to the board. I wanted to start by asking about the funding. So, actually, just a couple of observations on Turning Point. I found them incredibly professional, but actually, I just found the whole thing very accessible. So I can see why people, and there is obviously stigma, but it just felt like people wanted to go there and were kind of comfortable going there, and actually just the fact that they had those 6 or 7 service users who wanted to talk with us, and that's kind of a sign of a good service, right? Because they want to come and support our visits. So it was really helpful. But just on the funding, I read your section 5, public health, and these are statutory services that are commissioned. But can you just talk to us a bit more about these other grants? And I guess what I'm interested in, and what I was thinking about when I was there, is any of it under threat? Is there anything that we need to know about cuts, or we're going through budget process now? I just hate for them to be under pressure. So is there anything like that we need to be concerned about, especially with these grants coming to an end in March?
So there is a significant level of uncertainty about supplementary grants, unfortunately. So we've got no indication at the moment as to whether or not we will have these grants next year, or whether they will be continuing next year. So much of the work we're doing at the moment is sort of future-proofing a little bit to see how some of these services can come into business as usual and form part of the service moving forward. And if there were aspects of the service that have worked particularly well, what might we want to continue? And if so, where might we find the funding to do that? We find out very late generally with the public health grant each year what our public health grant will be. So we don't get that information with the council settlement, which tends to come out sort of Christmas time. So we tend to find out about the public health grant about 3 months later. So literally we will have set our budget by the time we know what our public health grant is. Likewise, with the supplementary grants, the Association of Directors of Public Health is canvassing quite strongly at the moment for us to know what the outcome will be, because obviously we can't commission on uncertainty, and it creates a great deal of uncertainty in the system moving forward. We also don't know kind of longer term whether or not there'll be some vision to try and absorb this into the wider public health grant as a part of a wider uplift of the public health grant. One of the aspects of both these kind of supplementary grants that I think it is worth noting is they're kind of double ring-fenced. So at the moment, as you say, public health of these drug services are a condition of the public health grant, so they're services that we have to provide. The supplementary services that we get come with what we call a double ring fence, so we can only spend this money on substance misuse services, and were we to decrease our core investment in substance misuse services, then we would lose our grants. So that's kind of how the system works at the moment to basically support this investment in our services. I think it's probably worth saying that the overall government strategy, kind of on the back of the Black report, has very much been recognition that having people in treatment is protected. So both for the individuals in terms of keeping people healthy and well, and people dying from substance misuse at a young age is obviously a significant concern totally. But alongside that, it's protective for wider society in terms of crime in society. And we know substance misuse as a whole destroys families, it destroys lives. So one of the reasons why it's really important that we're targeted in those places. The link with rough sleeping and homelessness is really quite significant. So we have particularly welcomed the rough sleeping grant because it's enabled us to support recovery in quite a different way. So being able to offer people accommodation as part of their recovery journey. So as they go through kind of detox, but then that rehab component, having that kind of guaranteed accommodation is really been significant. And as you know, one of the successes of Turning Point is its recovery model. So the fact that people are going through the service, but then going on into employment and really leading productive lives, it's one of the things we particularly rate about them as a service itself. The supplementary treatment recovery grant is very much about improving the numbers in treatment, and that's very much linked to the national strategy about having people in treatment as preventative. We do very well in terms of our outcomes for substance misuse, as you'll see in the paper. So our outcomes are amongst the best in London, which is something we're particularly proud of with Turning Point as well.
Just feels like there's some risk around the money, and that makes me concerned for Turning Point. And I mean, I'm sure they do have other funding streams. It's not just from us. But how much of a risk do you think it is for them?
But the way that, particularly for the supplementary substance misuse grant, which is the larger part of it, the way that that's been invested across our system, and our system is quite a mosaic of different providers. So whilst Turning Point and CGL are the main providers, we've got different organisations and the two different things within the states. Largely what's happened is to actually amplify some of the things that were already part of that service. In terms of it, there's it being a risk to Turning Point or others if that grant were to disappear. The core funding is still there. So the elements of the thing that this does as part of our mainstream service would still be in place. What this money is intended primarily to do, which is, as Anne says, increase the number of people in treatment. And that number might just then decrease the way it was gone as part of the established strategy. So it's not as if we would be at risk of having to stop an entirely new service.
Yeah, no, I understand. But I mean, for them, it would just be very difficult because they obviously want to do more and there's much more to do, and just to do it when they're doing such a great job.
So you will know 3 months after December. That's when we will have an idea.
So we don't actually know when we'll be told whether or not the grants will continue for another year or not. But when we get notified about the public health grant as a whole, tends to be beginning of the new financial year, sort of around that time period. So there's lots of canvassing taking place at the moment, and people are really flagging that you can't just stop services cold. So we need a little bit of notice as to what's happening. So we've got fingers crossed, but obviously it's quite a cold climate out there in terms of.
It's not just that public health grant chair committee. We unfortunately the burden of healthcare or local government is that we not just public health grants, the DCF. It's the adult social care grant. It's all the other bits that come with it. We get extremely late in the day, which, as you know, and it makes it so hard for budgeting year on year. I always find politically, I think it's very unlikely, perhaps, they would draw funding. But you never know these days, and what impact that has. But I agree with you, Turning Point's future and everything like that. But that's also one element that everything has to deal with all the time.
Yeah, well, it's good to hear for everyone to hear that because there will be changes, and not all of them are going to be positive. Sure.
No, I think one of the, I just wanted to highlight a point very much like what Lucy and Anne said. We were very impressed by the level of professionalism and passion, but also unity of the staff. And also it was extremely interesting to see how willing the ex-patients were to comment about their experience. And also some of them are volunteering or working in Tonyford, which is obviously the best criteria in terms of success model, in my opinion. I think one of the key success for them is the point 512 of the report, which is they had the waiting times extremely low, and quite iconically, one of the staff there mentioned that there is a moment in the addict mind where you have, you know, a sort of a flash where you want to do something, you want to fix your problem. And that moment in time, which is almost like when the penny drops, might last, you know, a few minutes or a few days. If you don't seize that moment, then that person goes back to a cycle of addiction. And I think that's where it's particularly interesting to promote is that they are there no matter what, and they're able to seize that moment and flip, you know, that coin successfully. And I think that's perhaps one of the most blatant, you know, sort of style they use in terms of how they manage to turn things around some of their patients, really. That's my own comment.
But just make a point on that. One of the things that works well as part of our system is as well as recognising those points is the overall availability of services. Quite often with substance misuse services, they might be 9 to 5, Monday to Friday. A lot of people who are new into treatment might be coming through the gate out of prison, and so on a Friday, the place is closed, but in the same site and the same part of the borough, and they're built on belief, fantastic charity, lived experience recovery organisation. They're open Friday night, Saturday, so there's a door always open.
And I think to go back to Anne's point on funding, I think if funding cuts were to happen, we just need to be vigilant that their timing, their waiting times will not be impacted. So I don't think they get necessarily the same success rate if they were to operate on a sort of 9 to 5, Monday to Friday, because I think part of the success is that ability to seize that moment, which is very often on a Friday night or during the weekends, rarely on Monday at 10 o'clock, let's face it.
One of the things we were talking about a little just before the meeting was one of the focus of the Turning Point's recovery model is around building up people's what they call recovery capital. With this grant group, it's doing really good things, but it's really driving numbers of people into structured treatment. And Turning Point spends quite a lot of time and effort before people are in structured treatment, getting them in a position where they're ready to do that, as you said, to kind of flip. So all the work around education, training, employment, getting people in the right space that feel like they want to move into treatment. It has always been their core. And so whilst driving more people to structured treatment is great for those individuals, and the system can handle it with that grant, actually their model is equally about making sure people are ready to do it and therefore more likely to be successful.
Thanks, Jeff. It's an observation as much as a question, is that we read in this report and we know that the work that Turning Point do in this borough is of a really high standard. You get several awards, you get ministers coming. And of course, Turning Point operate right across London and probably beyond London. So if we're looking recommissioning, plus in the future where money may be more difficult, are we clear what is it they do differently than other Turning Points in other boroughs and other organisations? What are the key things that we have to keep? And do we have a sort of priority of what we need when we're commissioning? Because it would be sad to lose the uniqueness of this and the specialness of it.
One element for me is very much around the recovery model, and I would be very keen that we continue to commission for that recovery model when we go out. And for me, that's one of the really unique successes of Turning Point. And they are the stories you hear about the people who've recovered and they've trained up to become nurses or outreach workers from Turning Point. And likewise, people who've got back into employment, education, skills training. That for me is incredibly important and something I wouldn't want to lose. if we were to go out to the market again, that would certainly be something I would be spending for quite heavily within an in contract.
And I think for me, Gerard, is when I went to Turning Point as well, it was something that I think we should take as much as possible. I think it's more of a cultural thing perhaps that Turning Point has, is their openness and transparency. So when I went, I had training in the administration of naloxone. There was an opioid overdose, and how that works, and just their openness saying, look, if you see someone, here's some naloxone, use it on a Mandarin, which we did at the time. But if you see someone on the street, and they may be having an opioid overdose, this is what you kind of do, and this is how you administer it as well. And I think it was then, and it was the service users and the doctors there as well, etc., who were encouraging that. I think was a really positive thing, because there was no necessary stigma or fear around it, and saying if you actually someone is an opioid overdose, don't help them. They're in a position where they may have not realised what they've done or what they've necessarily taken, and that can save someone's life. And I think that was a really positive approach. I think that people were encouraging, which I took away even now as a really impactful thing that they're really trying to encourage, and everyone was very positive and trying to promote that as much as possible at the same time.
One of the other things might be around multiple risky behaviours as well. Multiple risky behaviours. Yeah. I think, as we said earlier on, we commission our outreach sexual health prevention services from Turning Point 2. And as Gareth mentioned, we've kind of got these synergies across into the Club Drug Clinic and the sexual health services. So often behaviours cluster and risky behaviours cluster. So having that sort of links between services, but also elements of services where you're sort of dual commissioning, I think is actually really, really helpful for our population.
They also provide some of our mental health supported accommodation in the cluster of Central Florida. But I agree with that. I think that as well as us, staff in the council, there's system leadership across the different constituent parts of alcohol and substance misuse services, the charities that we work with locally, we commission, and as well as the specialist alcohol employers, specialist provision for young people. Also, their coordination with the diagnosis team, mental health services, and the police, and our own community safety staff. That role that is part of their commission service is really key.
I've been there several times over the years, and the passion of the staff is just incredible, and that must come through to the service users. It's incredible, and the way that there's an element of destigmatizing it, and the way that the service user work with open and just discussing their journeys. It's a very special place.
It's a bit, and also it's their kind of commitment to being there at the right time. Yeah. The example of that we had last week before last, when it was the first of the 2 dates of the early release from prison.
We
only had one person who was being discharged like the KC as a result of that, so effectively like a normal day. The Turning Point and planning for that were well advanced without having a lot of data. We're ready to be at all the right location where anybody might be. Just being available was a real kind of stand to it.
Yeah, it's big that.
Just a couple of points, if that's okay. Just a question to clarify the accessibility figure of 0.5%, less than 0.5% rather, who are needing to wait for more than 3 weeks. Is that 3 weeks since the point at which they present, or 3 weeks after they're sort of agreed to be taken onto a caseload? So how does that work?
That'd be the point which anybody received a referral.
Okay, all right. And in terms of the number of people who kind of complete treatment, do we have those figures? Sort of who are kept in the treatment programs?
We do. It changes over time because different people have different amounts of time they spend in treatment, but we sort of don't have that.
I think there's one at the in Appendix A, point 1. About a specific core service, the drug and alcohol wellbeing service, JAWS.
Yeah,
695
were in structured treatment in 2023.
So of the 695, 101 successfully completed. Yeah, and compared to, because obviously motivation levels will change, and you know, attrition rates are going to be an issue in this kind of treatment. But how is that comparable to other services?
We can share the API data we've got about there's public available fingertips data compares really well.
Okay.
So turning point service, particularly in Kensington and Chelsea, actually Westminster's more complex because of the higher volume of Russian population, which gives kind of makes their figures more challenging. But for Kensington and Chelsea, the proportion of people who successfully complete treatment and then don't come back within the given period of time to the KPL is some of the highest in the country.
And what do you put that down to? Why is it so good?
As Anne's described, it's that recovery model that they have, which is but somebody comes through the door, it's not immediately putting them into treatment or into residential rehabilitation treatment. It's working with somebody to where they are at that point until they're at the right stage and they have, back to that phrase, recovery capital to actually make a decision to enter.
Sorry, so what's the 3-week wait for to be if we're not starting the treatment straight away?
So that 3-week wait in a very small number of cases, I mean, where they don't have a key worker available to focus them on right at that point.
Okay, but the kind of engagement that happens then isn't the treatment at 3 weeks.
So that might not be.
It's not the treatment.
Yeah.
And I mean, there's understandably a lot of emphasis in the report about the links between substance misuse and criminality, which is understandable because there is a lot of concern on residents about antisocial behaviour. But really what is lacking and what doesn't come through in the report actually is the link with mental health and mental illness and suicide in particular. I mean, we're meant to be embarking on a suicide prevention strategy, and I don't think the word suicide is mentioned at all here. When, you know, half of all suicides will have substance misuse in the picture. And, you know, there is mention of kind of integrated support, and there's a reference to dual diagnosis as a paragraph, but that really should be something that pervades the whole thing. There's almost no differentiation between somebody with almost by, you know, it's a given that there will be a mental illness in the picture as well. It's quite rare that there isn't. So that did feel like it was missing, and I think there was a paragraph where it's mentioned that the link is being recognised more and more, but you know, the link isn't being recognised. It is there and always has been. So yeah, it didn't feel that came through, that the joined up working with mental health services and suicide prevention in particular doesn't come across in the way that the criminality question is repeated throughout the report.
And on that, it's the paragraph I'm checking at the moment, which says 20% of borough residents in treatment for drugs and or alcohol reported a mental health need, and we're not receiving any mental health support or intervention. So I think on what Mon is saying there, just understanding how you are integrated with the two services.
Yeah, and actually I think 32% is an underestimate. I think it's a lot more than that. And the list of services in the core services in Appendix A, there's very little in terms of mental health professionals that are involved in the care that's being provided. I think there are some social workers with mental health backgrounds, but otherwise there's no mental health provision at all. I just wanted that noted because we're not going to address substance misuse in a meaningful way if we're not also addressing mental health.
I think that's really helpful, and we have recognised that the dual diagnosis pathway is probably one of the more challenging pathways. And I think in terms of the history of substance misuse services as well, and at one point substance misuse services were predominantly in mental health nurse. And then over time, they've sort of transferred out into the voluntary sector. And in some way, that's been to the detriment of the dual diagnosis pathway, I think, and particularly in terms of a loss of expertise in mental health services, and how that's balanced across as well. So part of the work we're doing at the moment is reviewing, redefining and potentially recommissioning elements of that dual diagnosis pathway. So in terms of our area for investment, that's the area that we've pulled out. We do with some dual diagnosis services in-house within our everything across the table is our director for mental health, as well as our partnerships. So we hold within house as well. Again, in some ways unique, I think, our social services and the social services, particularly around supporting people with enduring mental health problems and substance misuse. And that's something that I think works very well. We've got quite a highly skilled team. And again, that will be reviewed as a part of the work we're doing around the dual diagnosis pathway. So yeah, that's suicide to a report. And suicide as well. I mean, we also have, just for your assurance as well, we have a drug-related deaths panel. We look at drug-related deaths in a lot of detail alongside our suicide panels as well. So there is crossover linkages that happens at that level. Also, we just refreshed our suicide strategy. We've just launched our mental wellbeing platform.
We've got the suicide prevention campaign that wellbeing after this launching on the 10th of October. Everyone's invited. We'll get invites to you. But yeah, no, that's a really good point, Councillor, on that front, because I think you're right. I think the issue of mental health and suicide especially, like you rightly say, especially have drug addiction issues, needs to be highlighted and perhaps needs to be obviously a bit more prevalent and presence in this at the same time. But as Anne said, do have process in place. We do have powers and stuff that perhaps don't come out in this report, which I do take on board and agree with.
Yeah, the only other I agree. I think it says more about this and looking at what to do is the club question, which is rather soon. There's a club drug clinic we commission, which is delivered by CNWF, and it's an internationally renowned service, led by Professor Owen Jones, and looking at different types of addictive behaviour. This service, particularly around club drugs, but they also have a gambling clinic with people with pornography addictions, etc. So that angle on mental health is part of the service.
Can I just ask one more question, just about the rough sleepers? Because obviously rough sleeping is more than doubled in the last 10 years or something like that, and certainly it's something that's quite visible in the north of the borough. Just what the risks are. I guess it goes back to Anne's point. Just what the risks are of that particular service being lost, because that's one of the two that's at risk, isn't it? The supplementary one and the rough sleeping one. Obviously, rough sleeping was meant to have been eliminated by 2024, but we're not there yet. So, yeah.
I mean, I think definitely the link between rough sleeping and substance misuse is well defined. I think this service has been really valuable. It's very much been a cross-council partnership as well, and our colleagues in housing, etc. This is something I think we will be looking at finding ways to maintain and bring into the service. There are definitely aspects of this we would want to continue no matter what happens to the funding. So we will be looking at ways of doing that. There's a lot of learning, and that's very, very positive.
Actually, that funding, we have partnership that's delivered that, and the commission has a strong mental health component.
I was just going to ask a couple of quick questions. One is in 5.10, which you say priority trends for us to address locally include substance misuse by our rough sleeping population, continuity of care for those in treatment in the criminal justice system. So on the misuse of our rough sleeping population, it's just substance misuse. Just wanting to understand because we heard a lot about spice being one of the main drugs that was coming up, what turning points were to it. So sort of who this is, what drugs you're seeing coming up on the streets most frequently, and then also in terms of the continuity of care for those in treatment coming out of the criminal justice system, the sort of representative Turning Point spoke about this the other day and her work in it, that just to understand what the local authority are doing to offer at a local level to offer prisoners support, kind of wraparound care when they're coming out of prison and sort of re-entering the community, what support we're giving there and how we are approaching that situation. Particularly, I mean, it sounds like it's not going to be chaos in terms of the nets or the numbers that we might have thought we were having. Even there was one, and I think there's another date in October.
Yes, there's a further date in October. We don't have data of the figures for those yet, as well. But I think, Gareth, correct me if I'm wrong, it's not just that Turning Point will help. It's just that one person that did get released from prison for RBKC, but obviously a wider borough area where Turning Point can potentially help others as well. We had 13 prisoners released as a whole across Westminster and Hammersmith and RBKC. So the service is providing not just for the one RBKC resident, but for all service users of the Borough population. But you're right, Chair, we don't have figures yet for the next round of releases of prisoners, which I think we mid October. 22nd. Yeah, but we'll look to that obviously, and obviously, as Gareth said, the service was brilliant in preparing the initial release. And how that may work going forward. The same one I'm sure that'd be exactly the same.
And just what I mean in terms of your role in that, what does continuity of care look like? So one of the powerful stories they said was the fact they were turning up and they picked up someone from the prison who wasn't going to get in the car straight to Turning Point, and then she did. And she said to them when she arrived, if I hadn't, I would have just gone and found Jack, so thank you for picking me up. But just obviously Turning Point have that role, but what are we doing locally as a local authority to ensure not everyone's going to necessarily turn to Turning Point, but is there other support or kind of we're working with probation teams to understand who might need additional outreach?
And one of this apparatus of government apparatus that's come out of this additional grant funding, which is helping us, is the Combating Drugs Partnership, which Anna chairs, and includes partners from across the different NHS services, the police, our community safety teams, a whole raft of people around the table, probation there too. And as well as kind of planning on the about strategy and future recommissioning of these services, there's been a kind of intense discussion with all of those partners over the summer in preparing for this, about making sure that the coordination of particular substance misuse services, probation and housing services are coordinated and kind of trying to be in the same place for people, I think is the key thing.
Yeah.
Whenever there are discussions with people who have been through these services, the common factor of kind of complaint or failure is on one day coming out of prison, having to go to the probation office, the housing office, get your methadone script, and one or two other things as well. And whilst for us, getting from Astley Road to a part of our borough might be straightforward, for somebody coming out of prison that's really complicated. So those things can be coordinated on one side, which is usually the probation side. That's what our Combating Drugs Partnership has been able to help coordinate, because everybody knows each other around the table and can bring the services together.
Yeah, that's good to hear. I think Gerard said in our meeting that it was sort of just that 1 minute or split second of something that you could do that can completely change the pathway of that person coming out. And I don't know if we have access to it, sort of those weeks before their release. And what we're talking about turning points when people come to them, actually getting their heads into a mindset where they're not going to go down that pathway again.
Circumstances, there's quite a long period of handover from within prison settings itself. So people are coming out, calls, so then the turning point that they get, their care plan in them has been known turning point or whatever provider it is, been able to work with them, and so that it's kind of ready when people are coming out. That's why there was particular nervousness about these 2 days for prisoner release, because the data came so late that if those numbers had been really high, it was quite risky. We saw that in some of the parts of the country.
Yeah. And then a quick question, then I know Linda wants to speak. Just an understanding of what, when the numbers we're seeing here, people who are going through this, you're being looked after by council, but also Turning Point, is it predominantly male, or is it sort of dominated by one particular sex or age group? And also in terms of the kind of dual diagnosis that Mona's just brought up, is there sort of trends that we're seeing there? That
I think I would need to go back and get that detailed feedback, the age breakdown. But one of the things we're really excited about with Turning Point over the past year, and I don't know if they spoke to you about it, was the women's service, which is something they have very specifically developed over the last year, really focusing on women's needs, particularly around kind of children and family. And particularly around recovery, and women sometimes having different needs around detox and maybe more community support and community recovery as well. So that's something that's really positive and has been very successful within the service. But I'll get you to break
that
down.
would, I think it'd be interesting to understand that data. And then Linda.
Yes, I apologise. I can't hear anything from people that
Okay.
the responses, so if I repeated, I apologise. As you know, we've had a hospital working party, and so we've had an opportunity to go into several hospitals. So it's either Look Ahead or Turning Point as the provider of the hospital, or Turning Point going into other hospitals to deliver services to their clients. So I think what's come out very clearly is the need for almost forensic specification of the contract, tendering, and also very importantly the monitoring of it. There's also the issue of people, for example, you say you have a good success rate on drug recovery, but what we have is people who do not engage. And so what are the processes that are being taken to engage? One clear issue is we have an outreach team that deals with rough sleepers, and they go out apparently 3 nights a week between 9 in the evening and 1 o'clock in the morning to cover the whole borough. But what we have is people in the streets during the day who clearly, we don't know necessarily who they are. We don't know whether they're associated with the borough or they just come in, but they're clearly vulnerable people with substance problems. And so I think there's a missed opportunity not to, and it means that the people probably that are begging, they're probably crashed out on the pavement. And so there's a very obvious presence that they're not actually being supported. So there's my things. This is been agreed with Mary-Therese Lossings.
But I'll just make a brief comment on that. Thanks, Councillor Wade. We've been involved in some of that work in Earls Court with the community safety team. As you say, Turning Point in particular, as our main provider of the substance misuse services, does have the substance misuse outreach into the hospitals and engages with the community safety workers who are doing the outreach on the streets. The data that we've seen, and I think you and ward colleagues might have seen this too, is that the majority of people on the streets in the daytime aren't our residents. So
they're still there.
They're still there. Yeah,
when it was very hot weather, all right, there were 5 of them crashed out, dehydrating, either using the canister things or whatever, but they were vulnerable. And they were there. They may not be ours, but we've got to ask them whether they're ours.
Absolutely, I agree with you. But I suppose the point I'm making in terms of the substance misuse service is to get them into a version of what we have. The community safety and police and those colleagues supporting them into those services in Islington and Fulham.
All right, I would say, all right, we have, as you know, a PSVO in Earls Court. We have wardens, but they wouldn't know how to engage with anybody with complex needs. In fact, because of the unpredictable nature of the individuals, they probably wouldn't know how to cope. But the fact is, those people are vulnerable. They may be associated with another borough. And shouldn't the borough that is supposed to be supporting them be aware of where they are in order that key workers can engage with them? But just not doing anything, I don't think is particularly effective. And it comes back to, we've been into the Look Ahead hostel, and as a local hostel, I would say that it's uncooperative with the community. If there is an issue, they're not prepared to take responsibility for their clients outside the premises.
Yeah, I think thank Councillor for those comments. I mean, I think there's a dedicated working group looking at the hostels issue. So I think maybe some of those questions might be better looked at there rather than asking Gareth.
Or Linda, I mean, I'm very sure we said this Portia this week who had a situation she wanted to speak to Tanning Wood about. I think if you were to contact them directly, it would be very open to understand. No?
We do contact.
Okay. We do. I'm going to just Portia left one question, which Linda, do you mind if we, unless.
Could I just say one thing before that, just in relation to Linda's point about the positive outcomes and completion of the treatment figures, just how positive those figures are. That's that is excellent and to be commended. But I think those are the individuals who have come forward and shown motivation are at a moment where they feel that they want to make a start. There is a huge kind of unseen group, unacknowledged group in the report who are the people who are abusing substances and dependent on substances and putting themselves and others at risk because of it, who aren't being caught up with. And I guess the work is around also identifying them, I think, and bringing them on board. I appreciate that will mean a massive increase in the demands, but that's what's maybe missing here is those individuals who aren't yet fully committed to. And I appreciate that needs to come sort of a self-motivation thing, but that's maybe not us. Sorry.
No, don't worry. So Portia just left us with a question saying, what education is given to those in your service about crime prevention?
In the alcohol and substance misuse service?
Yes.
Well, the staff at Turning Point, at CGL, Children for Life, all of these organisations that are part of our system, all work really closely with police in particular, but also our community safety teams. And so there is, as part of their learning and development programs, dealing with criminal behaviour and community safety issues is part of the programme, but a key work of the substance misuse service. They would expect to be working with people who have a background in crime disorder. And so part of their core competencies will be understanding how to work with those individuals. And Turning Point, I'm sure they'd be quite happy to share some of the learning development programs. So,
okay.
Yeah.
Thank you very much, everyone. And I think the ask was, I don't know who asked this, but sharing KPI, did you say? And then just understanding a bit more about the age breakdown and is it predominantly more female or male would be really helpful. And then just a couple of recommendations and the committee group to prioritise more support for those who are homeless or rapid sleeping, which I think has come up a couple of times. Give additional support to those with a dual diagnosis of mental ill health and substance misuse. Recommendations to leadership. And then thank you.
Thank you, Chair. Thank you.
We are on to agenda item 6, which is the work programme report. This report sets out the development committee's work programme, identifying priorities of the leadership field. Yeah, see that web. Select committee members that are recommended to agree the detailed work programme for 2024-2025 and set out as set out in Appendix 1. Note that the report on the Mixella Centre will be discussed by the Overview and Scrutiny Committee on Wednesday, the 23rd of October 2024. I'm happy with that. And then if anything from the Mixella meeting with OFC, please to come to us and it come to us after. And everyone, yeah. And then we therefore now conclude the meeting committee.
Sorry, just on the forward plan. Where are we on the suicide working party? There's no mention of suicide in any of that. There's all.
So we scheduled the final report to get us the last meeting of the year, which is the 29th of April 2025. And I have to be frank with you, it's been quite difficult to get meetings in the diary because of the amount of activity going on across the scrutiny functions and the priorities of Grenfell and the priorities of the budget. So the officers have been very helpful and we're ready to go with the first working group meeting. It's just finding the time for the diary, Councillor Hargreaves.
It got pushed up.
It just seemed to have been pushed a lot.
Yeah. Predominantly because of the additional jobs committee and that as well.
And also there's additional,
but it is very much now, I think, ready to go. I don't know what the first thing is.
okay, so we'll look at the November meeting. Yeah.
Oh, okay.
Any, yes.
Yeah, I was trying to ask very quickly. I appreciate that the Grenfell Jones NA came to the July meeting.
Yeah.
But is there going to be opportunity to revisit that just in light of the publication of the phase 2 inquiry? Is that happening?
Yeah, I'm sure. Right. Can we do that later? What's it going to see everything out?
It's just that because there is a lot of activity, as you say, and it would just be good to have that kind of have it acknowledged here. I appreciate it was only in July that it was discussed, but yeah, just a thought.
Can we come back to
you?
Yeah, I mean, it might be an idea might be that you could ask for to come back 6 months or a year time, update on recommendations and the recommendations from the Grenfell JSNA refresh.
6 months pushing it, 6 months or a year pushing it. I don't know. I just thought in the context of all the other activity around Grenfell in light of the publication of the report, whether the JSNA would be something to revisit. It's just a thought. It's not something I'm recommending because I do appreciate it only came in July. Don't have to answer that.
No, we'll come back to you and talk about how best we can. I will now conclude the meeting. Thank you to everyone for your time and attending. Thank you, Joanna. That was quite long.
Yeah, we got that. I got that.